again, I was wondering if you could tell us why you decided to enter into medicine.
A lot of factors. My father was a pharmacist. He was a frustrated physician. He was had to foreshorten his education so his younger brother could be educated. In those days, in families, there wasn't enough money, so only the men got educated, the women didn't. And there had to be enough for everyone, so he became a pharmacist instead of a physician. But he studied medicine, even though he was never going to practice medicine. And he conveyed his love of medicine and his feel for people to me, and his scientific bent. And I was going to follow him in a career in pharmacy, but he died when I was 13 years old. So by the time my choices came, pharmacy was a 5-year program. May as well go on another 3 years and become a physician. So I did, and a choice I've never regretted.
Where did you attend medical school?
Harvard.
Harvard. What year did you graduate?
1964.
Do you remember approximately how much it cost?
Yeah, it was about $2,000 to $3,000 a year, and that was pretty much the total cost. First year I roomed in, and after that I acquired a wife who helped put me through the rest of medical school.
Did you have to take out any loans or anything?
Oh yes, oh yes. I was paying off loans until I was 40 years old. Looking back, the loans were rather small, but it was a lot of money back then.
Yeah. How do you think the cost of medical education when you went compares to today's cost of medical education?
I think they're pretty much the same. College and medical school tuitions have just about kept pace with inflation. Some wag once said that the cost of a year in college is about the cost of a new Chevrolet. And it was true way back then, and it's true now.
It's true when you think about it like that. So after you graduated from medical school, you did your internship?
I did an internship in Boston at the Peter Brigham Hospital, and was planning to go on for residency, but Uncle Sam intervened. And I spent 2 years serving with the Navy, serving with the Marine Corps. I was a naval officer serving with the Marine Corps. Did a lot of field medicine, did some interesting stuff.
Were you out of Vietnam? Or?
No, I never got to Vietnam. But instead of going to Vietnam, I went to Puerto Rico. There's an island in the news right now called Vieques, where there's a controversy about whether the Navy should continue bombing on the bombing ranges on this little island of Vieques. Well, that's where I was stationed there for 6 months. It was interesting.
So you treated the soldiers? And
treated the Marines. And no, didn't treat family, just treated Marines.
So how long was your commitment with the...
2 years.
2 years.
It was, back then, I considered it somewhat of an interruption to my career and somewhat of a waste. But as time went on, I realized it was not a waste of time at all. I learned so much about the way the world works and about what people do for a living, and that helped me a lot in my later career. I think it was Hippocrates who said that show me what manner of work your people do and what manner of food they eat, and I will show you what diseases afflict them. Well, I learned a lot about what people do serving in the military.
Sounds like it was a very good experience.
In retrospect.
Yeah.
In retrospect, it's a good experience, yeah. And then after the military, came back to my residency. They were kind enough to let me resume my residency in Boston. Finished out a residency in internal medicine, and then went on for a couple of years of fellowship in pulmonary diseases, which was a brand new field back then. There were no pulmonologists. I was the first class of pulmonologists.
So what led to you choosing your specialty?
That again was sort of dumb luck, but you make hay of your opportunities. I was planning a career either in nephrology or cardiology and had actually lined up a fellowship in cardiology before I went into the service. By the time I came out of the service, the fellowship had changed a great deal. The person who was in charge of the fellowship had gotten a lot of grant money, and that really changed his style of practice. He was off talking and doing other things besides teaching, and the fellowship wasn't as desirable, I thought. And I was casting about for something to do, and my chief of medicine was a wise old fellow, said, "My boy, I have an opportunity for you." And when he said something like that, you knew you were about to be made an offer you couldn't refuse. And the hospital had acquired a new pulmonologist who needed fellows. So I was volunteered to be one of his first fellows, and it turned out to be one of the most exciting fields I had ever dreamed of. It combined everything I wanted, all of the science, a lot of machinery, and I love machines, and a lot of physiology, applied physiology, stuff you could read in the books and then go and apply it to patients. So that really fascinated me, and I was hooked on it.
Was it difficult going into a specialty that was almost uncharted? Like you said, it was a brand new specialty.
Well, you didn't have a lot of competition, so in that respect it was pretty good. No, it wasn't particularly any more difficult than any other specialty at that point. There was new knowledge being acquired at a fantastic rate in the late 60s in all fields, so it really wasn't anything different. There was so much more new knowledge in pulmonary being acquired that it had to split off. It was really a sub-specialty of cardiology until that point. But now there was more knowledge than the cardiologist could absorb. So it needed a new area, a new organ field.
So after you finish your residency, did you come out to the Worcester area to practice, or did you begin practicing in Boston?
Actually, I went back to my hometown of Framingham. One of my professors in Boston was invited to come to a new teaching program at what was then Framingham Union Hospital, now Metro West, to start a teaching program there. He had migrated from Harvard to BU and was a professor at BU running the teaching program at Framingham Union. And I called on him and convinced him he needed a pulmonologist. And he hired me, and I started the pulmonary department at Framingham Union. About a year and a half later, he was invited to come to Worcester and be the first professor and chair of medicine here at UMass. His name was Roger Hickler. And he was kind enough to ask me to come along and start the first pulmonary department here at UMass. That was back in 1971 or 72.
That was only a couple of years after you began practicing.
Right.
Wow. What did you enjoy particularly about practicing in the Worcester area?
Worcester was a city that was really coming into its own. The medical school, of course, brought a great deal to Worcester. It really put Worcester on the map. I grew up in Framingham. That was my hometown, as I mentioned, and Framingham was a very small country town. Anything we needed in terms of, you wanted to go clothes shopping, you went to Boston or you went to Worcester. Frequently we came to Worcester, and I remember coming to Worcester with my parents when I was very young. And all I can remember was this sort of dirty, gray city. It really wasn't very attractive. And when Dr. Hickler asked me to come to Worcester, that's what I remembered. I said, gee, I really am not sure I want to live in that area. But when I came and looked again, 30 years later, it was changing, and for the better. Nice small city, compact, good schools, fairly decent tax rate, low crime, low traffic. and a lot of money coming in, a lot of new industry coming in, a lot of educational institutions here, and it became very attractive. And Worcester has continued to put itself on the map over the last 30 years.
So you helped initiate the pulmonary department?
I was the pulmonary department. I was it. There was no other pulmonologist here. There were 2 other pulmonologists in the city of Worcester, actually 3 in the city of Worcester, 3 physicians who were practicing pulmonary medicine. They were clinicians. One was fairly academic, and the other 2 were practitioners, and they really needed someone who was going to be a full-time academician and researcher, as well as teacher and clinician. So I was interested in everything. I was very young, very enthusiastic, and didn't have a lot of experience, but I was willing to work hard at it.
So what was a typical day like for you?
There was a lot of administration, a lot of systems had to be started. The respiratory therapy department had to be built, teaching programs had to be initiated for residents, for the medical students. That's where I really started out, was doing teaching programs for the medical students. And then, so my day was filled. I'd be in here, 8, 9 o'clock in the morning. I was never one for really early morning hours. And would leave here 7, 8, 9 at night. And it was virtually 7 days a week. And as the hospital opened in 1974, it was even more work then. There was no hospital when the medical school first opened, and I had to have some hospital to work with, Dr. Hickler also. So we were at Memorial Hospital. At that time, it was the Memorial Hospital. That was the official name. And that's where we did our work. That's where we did most of our teaching. The resident staff would come over here to the building that's on the corner, which was a former tobacco barn, as I believe, and now is an administrative building. The semicircular building, the quarter-round building, right on the corner of the lake and Shrewsbury. It was pretty much an 80 to 100-hour-a-week job.
Pretty busy.
Pretty busy.
And did you have a family as well while you were going?
Oh yes, had a wife and 2 kids, and they didn't see a heck of a lot of me.
What do you think it was like for them to have a busy practitioner as a father?
Well, I know my wife did not like it, and that led to a later decision of having to make a change. My kids never complained about it very much. I always managed to be there whenever there was some important event occurring in their lives. My kids said to me about whether they wanted a career in medicine. My son expressed it best. He said, "No, I would never think of going into medicine. I don't want to work that hard." My daughter toyed with a career in veterinarian medicine for a while, but decided to go on into other things.
So it was a difficult balance.
Yes. And it became more difficult as the clinical work here at the University Hospital ramped up. And eventually, after a couple, 3 years of doing that, virtually alone, my wife presented me with a choice. Either I cut back on the work, which was not possible to do at that moment, or we were heading for some sort of a breakup in our family. So I made the choice that I wasn't going to, my family was more important to me. So I made the choice, and I left here at UMass, and at that point an opening in pulmonary had come about at Memorial. And they were kind enough to take me back there. That's where I finished out my career at Memorial.
So when did you finish practicing medicine?
Well, this problem with this neurologic problem that I've developed cut my career a little bit short. I had to cut back on my clinical work about 4 years ago, and I had to quit completely about 2 years ago.
So you practiced in the area over 30 years?
Close, yeah, close to 30 years.
What sort of changes did you see happen in Worcester over that period of time?
You know, it's hard to put a finger on that. Changes occurred so gradually, so incremental. It's hard to point to any major change. Of course, you look back over 25, 27 years, and of course there have been startling changes. I think the major changes have been, well, the growth and influence of the medical school, the growth and influence of the Fallon Health Plan, the occurrence of HMOs and managed care made startling changes in the way the styles of practice. And then, of course, there are all the scientific breakthroughs, technological changes that occurred that weren't peculiar to Worcester. But we were an academic center. We got all these changes very early on. We were among the first places to get CAT scanning and all the other marvelous technologies that really improved our ability to take care of patients and to be able to do things for patients. It was almost the kind of change, the quantum change that occurred, I think, probably back around the early parts of this century when scientific medicine overtook the kind of shamanism that characterized medicine in the late 19th and early 20th century. And then there was another scientific revolution starting in the 60s and 70s that again sort of was a revolution in what we were able to do for patients. That made things much more gratifying.
Felt like you were able to do more.
Mm.
You kind of touched on my next question, which was what sort of technological innovations have influenced your career and your specialty?
TMTC. Too many to count. Now, that was an abbreviation we used a lot when I was a house officer, and because we did our own blood counts. So I was familiar using a little glass hemocytometer and a microscope to do white counts. Did you ever do those?
Yeah, I worked in the lab for a few years and did research, and we used the hemocytometer, we didn't have the automated counter.
And doing urinalyses with ourselves with too many to count white cells in each field. Well, the technological changes have been like that, almost too numerous to count.
Yeah. What are some of the bigger ones, you think, especially in the field of pulmonology? Because you mentioned it was such a new field when you got into it.
Yeah. There are patients that stick in your mind, and when I was a house officer, and there was an elderly gentleman who came in with COPD and respiratory failure, and I can remember the way we did blood gases then. We did blood gases chemically. There was an apparatus called a Van Slyke apparatus where you chemically determined the PO2, or the amount of oxygen in the blood, converted that into a PO2. It was a very long, laborious process. It took a good hour to do a single blood gas determination. Full-time job for a technician. So we didn't do very many of them. It was just too inconvenient, too expensive. And those patients, we had no data on those patients. They died. And I can remember losing that particular patient, and it stuck in my mind. And when I became a fellow, or was about to become a fellow, and was looking at pulmonary, you know, what could we do for those patients? We have no data to care for them. But by the time I was a fellow, we were no longer doing oxygen determinations chemically. We were doing them with a technique called a polar electrode was what we were using. It was a chemical electrode, and we could now get PO2s fairly reliably, fairly quickly. It was still a 20, 30-minute procedure, and the machine had to be warmed up, so you had to warn the technician that the specimen was coming. And we did brachial artery punctures, because that's the only thing we've been taught to do, and that meant someone had to stand there and hold. It was a long and laborious process. And within a matter of 3-4 years, those techniques of polarography, that's not the correct term, but I can't remember exactly what it was, developed into the blood gas machines that we have now, and they became rapidly better. And we developed the technique of small artery puncture, like radial artery puncture, to get arterial blood. And small samples could be used. And it revolutionized what we were able to do with the patients. And shortly thereafter, there was the development of good mechanical ventilators. And suddenly we could support these patients until they got better. And there were a lot of other diagnostic and therapeutic techniques that came along at the same time.
What about major drug changes?
Oh.
That's been a revolution as well.
Oh. As an intern, I think we maybe knew 4 antibiotics, 1 diuretic. Chemotherapy was virtually non-existent. It was primitive. It was really primitive. It was a lot easier to make your choices because there weren't very many. We did not have CAT scanning. We did not have, the best we had for imaging was something called laminography, which was an X-ray technique where the tube was swung and the plate was swung underneath, so that only the focal point, the pivot point, would be the only thing in focus. Everything was out of focus. And then you just put in another plate and change that pivot point and take another X-ray. And then you'd have to line them all up, and you might be able to pick out certain lesions, a cancer. It was a far cry from CT scanning, but it was the forerunner of CT scanning. Ultrasonography was being used mainly to outline midline shifts of the brain if you suspect someone had an intracranial lesion. There wasn't much else in the way of diagnostic. The cardiac catheterization was just coming into its own. The idea of floating in a Swan-Ganz catheter was a long way off. Things were really very primitive. We had one patient I remember had as an intern who came in with severe congestive heart failure. He was a frequent flyer. We'd managed to get him dried out, but even though he was doing everything he could, his failure was so bad. And all we really had was digitalis. Digitalis leaf was the usual drug used, a crude, brown, round, spherical pill of crude leaf rolled up. And there were some purified forms, like digoxin was available and digitoxin was available. These were tough drugs to use and had to be used with care. And we saw a lot of digitalis intoxication. But this patient came in with severe heart failure. And we were using what was called mercurhydrin, a mercurial diuretic. And we did things like a Merc sandwich. Mercurhydrin worked better if you gave patients aminophylline. So you'd give them aminophylline IV, mercurhydrin IM, and another dose of aminophylline IV, and hopefully they'd urinate some. This guy had 30, 40 liters of edema fluid on him, and he was going to be in the hospital a long time. One of our cardiologists came to us and said, I've got this new diuretic that I want to try, and we're looking for such a patient. And the patient agreed to be, by the way, there were no institutional review committees. If you wanted to try some sort of an experiment, you got the patient's permission and you tried it. And he said, this may help. It's a pill called ethacrynic acid. It was the forerunner of furosemide. We gave this patient 1 pill of ethacrynic acid, and he peed out 30, 40 liters over the next 36 hours. His penis was sore. He was peeing so much. It was miraculous. Just the beginning of all of those things.
Must have been great, just having something like that come along where you go
Yeah.
from what can I do for this person to giving them one pill and seeing that much of a change.
It was miraculous.
And I'm sure you've also seen a lot of changes as far as managed care goes as well.
Yes. Physicians had pretty much free rein. We could do whatever we want and charge whatever we wanted, and that really, at that stage, there was nothing wrong with it. One of the things that I believe is that physicians really never have had control of the medical system, the healthcare system. They deluded themselves into thinking they did, and as long as there was no conflict between society and what the physicians wanted to do, no problem. But as soon as medicine became as technological and physicians became somewhat isolated from their patients and the costs began to go up at a fantastic rate, now society started putting brakes on what physicians could do. And physicians had a rude awakening that no, they really weren't in control of the healthcare system. Society always has been. I mean, from the time of the pharaohs, society has always been in control of healthcare. We American physicians, or probably worldwide physicians, went through a period of 100 years where we had free rein because we weren't impinging on the control system. Now we were.
It's a very interesting perspective.
And the costs of healthcare became fantastic, and they're still, in this country, they are still unbelievable, fantastic, and perhaps not what we should be spending. That's another question.
Do you think managed care has influenced the quality of care a patient receives?
That depends upon how you define quality. In terms of, do patients get generally what they need, what they should be getting? Are they being managed? Are they getting the optimal level of care? I think probably they are. They may not think so, especially here in this country, where optimal quality is frequently defined as the most expensive or the latest, whether it's been proved to be effective or not. I think that quality has not been adversely affected by HMOs in general. Specific cases, yes, there are some horror stories, but there were horror stories before there were HMOs. Only we took those situations and handled them by burying the patients in a cemetery. There were all sorts of things that were done wrong. Some of the research that we did, like the ethacrynic acid story, which were there were other drugs that were tried where the outcome wasn't so happy. I think that a certain amount of controls and a certain amount of introspection as to what is the most effective and most efficient medical care has been beneficial, and I think will continue to be beneficial. And it's going to produce some changes, some more changes in the style of practice. But I think in the long run, those are going to be good for physicians and patients.
I kind of find your perspective interesting about the healthcare industry never being in the physician's control. And I was wondering how you see things going in the future, if that is the case.
That depends upon how politically active physicians are going to be. We had an opportunity about 10 years ago, 9 years ago, that was absolutely blown. Not physicians' faults. There were, well, let me not beat around the bush. say exactly what I mean. I was at one point in my career president of a national organization of pulmonary physicians. And President Clinton was elected during my tenure as president of that organization. And after he was elected, one of the people in our organization had had significant contact with him and his wife and felt certain that we could get some sort of advisory position to Mrs. Clinton's panel that was looking into a new healthcare system. And we were very much disappointed that we were not asked. In fact, no physicians were asked, or one was asked. Physicians were deliberately excluded because they were going to be in there beating their own bush. They were going to be too self-interested to be part of this. So they had to be excluded according to the view of the Clinton administration. And that was very disappointing. And it didn't go anywhere because the right people weren't included. The right people have to be included. Physicians are still the people in the best position to know how a healthcare system should be built. And they have to be part of the equation. And unless they stand up on their hind feet and make sure that they're in there, it's not going to turn out well. The thing that is disappointing to me is that physicians should not wait to be asked. Physicians should be organized and up there and with plans out in the forefront. As someone said, trying to organize physicians is like trying to herd cats. But I have hopes. There have been some good plans put forward by some good organizations, and I hope that they'll get more widely listened to.
So do you think we have adequate representation as it is now through the AMA and other societies, or do you think we need more?
Oh, we need more. Yeah. The AMA, in my view, in my humble opinion, has been obstructionist. They have been primarily looking out for the physician's pocketbook. And with that as your primary goal, you're not looking out for the good of society. And physicians should be looking out for the good of the society we serve.
I agree. To kind of change topics completely, how do you think the doctor-patient relationship has changed throughout your years of practice?
That's probably the downside of managed care. Managed care has forced the physician into reducing the amount of time spent with patients. Part of that is the needs of the plan, whatever it is, whether it's profit or not for profit, to keep itself in existence financially. So a certain amount of revenue has to be generated, and physicians are the revenue generating engine of managed care, of any managed care plan. Without the physicians doing what they do, there's no money, there's no income. So more patients have to be seen, and there's just so many hours in the day, so your time with each patient is cut. How can you build a relation without spending time on it? I don't know of any relation, whether it's a family relation or a patient relation, that can be built in a short space of time. So how do we have physicians spending more time? Well, there has to be better reimbursement for each patient. How do you increase the costs of the system? Well, by cutting the unnecessary costs. And we still have a system where the overhead is, I don't know, 20, 30%. And we still, well, here's a nation which spends half again as much as any other nation in the world on its health care, and we still, according to the WHO, rank 37th in the world. Our outcomes are no better than Canada, Germany, Italy, France, but we spend almost twice as much as some of those countries. And it's going into pockets where it shouldn't go, and for things that are not really effective. But that's part of the problem is us, the American people. I'm speaking as an American. We demand impossible things of our healthcare system.
Is there any way you think we can change that view of society?
It will change. It will have to change. There was a picture I saw in the paper a couple of years ago of an elderly person lobbying outside the Capitol building in Washington, carrying a sign that said, "We want affordable health care now." An economist has pointed out that in healthcare there are three things that would make for a perfect system: high quality, easy access, low cost. Pick any two out of those three, because you can't have all three. There has to be a balance of what we spend and what we get, and who gets what, because healthcare is a bottomless pit. There's no limit to the amount of health care you can demand. We have to put limits. There have been some early attempts to do that. The state of Oregon with its Medicaid program, flawed but a reasonable attempt. And I think something along those lines will eventually come to pass in this country. I hope it doesn't take a major crisis to force it.
It seems like nowadays, 2001, there's a lot of problems as far as Medicaid, Medicare reimbursement goes, teaching hospitals. UMass in particular is having a problem having to lay off quite a number of people.
Yes.
Because they're not getting reimbursed properly. Just wonder if you have any thoughts or comments on that.
Well, hospitals, 2/3 of the hospitals in this Commonwealth are in the red, and I think that is mirrored pretty much across the country, because people, and that means the government, aren't willing to pay the costs, and they aren't willing to limit what has to be done. And the only way this works, in my view, is that there has to be a national health system devised. A single-payer system, and again, in my humble opinion, a single-payer system. It doesn't have to be socialized medicine, whatever that means. It's a shibboleth that is waved around whenever someone talks about a national health system. And by the way, if Medicare isn't socialized medicine, what is? We need a national health system with a global budget and a political decision by our citizenry as to what we will pay for whom, what constitutes a basic health care package, and what will be in that. And everyone gets that. And then if you want to buy more on your own, so be it.
So change topic again. Do you have fond memories that you look back on
Oh,
over
yeah.
the years?
Yeah.
You could share with us?
TNTC. I thoroughly enjoyed my career in medicine. I'm really having to give up because of my neurologic problem was a blow. I love practicing medicine, and I would love to go back to it if I could. That's not going to be. So I've got my memories, and there are lots and lots of fond memories. The teaching, I came to UMass because I love teaching, and I miss the teaching. I love taking care of patients. I miss the patients. I loved some of the political challenges. I miss that. There were a lot of enjoyable things. Seeing patients get better, seeing students graduate. Lots of fond memories. Lots of good people.
What sort of advice would you have for a young medical student or physician just entering into the profession?
You're going to have a wonderful time. Keep focused on what it is that makes a physician, and keep focused on what the true rewards of practicing medicine are. And those aren't financial. They are the privilege of taking care of your fellow human beings and helping them live good lives. Because that truly is a privilege granted by the Almighty.
I want to take a little bit of a step back to when you first came to the medical school and started up the pulmonary department. What sort of challenges did you see in getting a medical school off the ground? Was it met with opposition from a lot of the hospitals around, or was it accepted?
No. There was a lot of opposition. There was a recognition that the medical school was here and it was a force to be reckoned with. But that is not to say there wasn't opposition. Medical school initially, the initial thought was the medical school, and I think perhaps the initial mission, thinking about the mission of the medical school at first was the medical school and the hospital would not be in competition with the hospitals in town. It would be a small hospital. It wouldn't take patients away from the other physicians in the other hospitals. Well, you're going to make a tertiary academic center. That's a foolhardy expectation. And of course that did happen. And there was some rancor. And it came at a time when there were other financial constraints on hospitals, and hospitals had to close. And a lot of them, I think, would back then pointed the finger at the medical school and said it was the medical school's fault that we're going out of business. It wasn't. The medical school had to be built. I think its being in Worcester was a great thing. And that's life. Were there problems? Of course there were problems. One of the biggest problems in starting a new institution is that things have to be done now. We've got students here, we've got a hospital opening, we've got patients. How do you do things between now and tomorrow when there is a system in place, a legal system that says that you have to go through certain steps in order to buy a piece of equipment or to hire a person? The short answer is we circumvented a lot of the legalities. And I'm sure if we were doing those things today, we'd probably wind up in jail. But they were necessities back then, and we did them. But it worked for a couple of years until things were up and running. And like any new entity, there are people that are adept at getting things up and running, and then there are people who are adept at keeping them running. And the two aren't necessarily the same. And I think I was one of the first and not one of the second. And that was, and that and other things meant that it was time for me to move on.
Did you model setting up UMass after anything that you've seen in the past, or?
Yes, there were pulmonary departments that I saw in places that I trained in Boston, and I modeled Framingham Union and Memorial Hospital and Hahnemann Hospital, where I set up pulmonary departments, and here after a system that I saw at the VA. I had some good teachers there.
You have to be a visionary, I think, to generate something from nothing.
Yeah. I always had highfalutin ideas. I'm not sure my execution was always all that good, but the ideas were good.
Can't expect everything to go through. Do you have anything that you'd like to discuss that we haven't talked about?
Ah. Some of the questions that were in the handout that preceded this interview. How has Worcester changed? The ethnicity of Worcester. I always found Worcester ethnologically fascinating. One of my favorite pastimes was to go down into the X-ray department, and if I had a few moments, instead of looking for a particular X-ray, there was a big rack with all of the inpatient X-rays there, and just go flipping through that and looking at the names. And you had all sorts of names. You had Irish names and Swedish names and Jewish names and Indian names and Oriental names. Every ethnic group, Russian name, every ethnic group you could think of was here. And Worcester has continued as more waves of immigrants came to this country. The Southeast Asians came in, the Hispanics came in, and that's been, I think, one of the strengths of Worcester is its ethnic diversity. It's sort of a miniature of the melting pot that made this country as great as it is. And Worcester has grown to take advantage of that. There was another question about women in medicine, minorities in medicine. Well, certainly when I first came to Worcester, I think the number of women that were actively practicing in our hospital, you could count on the fingers of one hand. There were virtually no minorities. And as towards the end of my career, I think half the practitioners, close to half the practitioners were women, and 25% were minorities. Again, that's we've taken those sociologic changes and made them part of the strength of Worcester medicine.
I think that kind of goes hand in hand with Worcester being such a diverse area.
Mm-hmm.
You need a diverse base of practitioners.
Yes. Yeah. Let me just amplify one of the things about the rewards of medicine. I was at an anniversary party for a friend of ours and ran into a young man there who had just finished, he was a graduate of Harvard College and had just finished his first year at Yale Medical School and had gone off for the summer to be with his uncle and grandfather at their medical office in Wisconsin, and had spent the summer there and was now on his way back to his second year in medical school. And I asked him how he enjoyed, what he did for his uncle and his grandfather while he was there. And he said, oh, I helped out taking preliminary histories and taking blood pressures and talking to patients. I said, how did you enjoy that? He said, I had a ball. I said, but the one thing I can't understand is all my uncle and grandfather did was complain about how bad things are now and how things were much better in the good old days, but I had a wonderful time. This was someone who was going to be a great physician. And he really understood where the rewards were. Still the same. And to any young person who is thinking about a career in medicine, go for it. It's a wonderful way to earn a living.
It's interesting you bring that up, because I have that same thought once in a while. A lot of the older generation physicians do complain of how things have changed, and when I go in and I see patients, I leave completely fulfilled.
Go for it.
It's a good story. It was only a few minutes, and I can't think of any other questions. We touched on a lot. I really enjoy listening to your political views. I think you have a good grasp on that.
Well, I was, one of the things that I gravitated towards as my career went on, grew out of some of the problems we have with in caring for patients in critical care units. When do you let patients die? And from there we got into medical ethics, and I ended my career teaching medical ethics, and set up a program at Memorial Hospital for teaching the residents and the students who came through medical ethics, and did that for a couple of years. Dealt with the Health, Life, and Society course here with Drs. Clive and Clay. The medical ethics got me into justice, and that got me into healthcare financing, and the kind of non-system that we have and the kind of system we should have. So that's where I developed my political views.
Have you ever been able to speak out?
As often as I can. But now I speak out not to the people that you got to pick your you can't preach to the choir. So I don't talk about it very much to my medical colleagues, but I talk about it to every lay person I can, because they're the ones that are going to have to make the decisions. It's got to be a political decision as to what sort of healthcare system we have. And that is not going to be decided by physicians. It should be advised and led by physicians, but they are not going to be the decision makers. They shouldn't be the decision makers.
Were you ever involved with the medical societies at all?
Mm-hmm. Yeah, as I mentioned, I was president of a national organization for a couple of years, and I chaired some committees for the Worcester District Medical Society, and I was in a lot of political organizations, professional political organizations. I was a joiner.
Were you ever able to bring about any changes, or?
Who knows? I hope so. I hope so. Small, incremental changes. I don't know. You never really know. It's like raising a child. You never really know how your work is going to turn out until 20 years later.